cardiovascular system. And up till now, we have covered some of the points. Actually, sometimes we just try to target one of the disease, and actually, it is difficult to learn one disease if you don't have the concept of the surrounding pathologies which are attached to it. Okay. So with that motto, I have just started in a slightly atypical way. We have discussed some of the points. We started the shock at the moment, and we have covered some of the points related to hypovolemic shock, septic shock, cardiogenic shock. Okay. So today we will just try to focus what is obstructive shock. Okay. So what do you think? What is obstructive shock? Anyone, please? Because
When there
in
is some obstruction in outflow of the blood from the heart, maybe due
okay.
to cardiac tamponade or tension pneumothorax or constrictive pericarditis, and the
Mhm.
pump is all good and there is no hypovolemia or other things, but there is not enough space for heart to contract properly and pump the heart out, the blood out of the heart.
Yes, very good. So it may be some cause related to lungs, like in the thorax, there is obstruction. Okay. So it is maybe related to anything which is itself occupying the chambers, near the chambers, like the cover of the heart, which is pericardium. Okay. Or there is something outside which is compressing the vessels. Okay. So usually it will be like that. Or for example, if it's something which has obstructed the chamber itself, so it will also be like that. And another type will be any problem related to valves of the outflow tract from the heart. Okay. So all of them will be included in the pathology which we are discussing at the moment. Okay. Just a second, please. Okay, so to start with, do you think will volume effect, like if we try to cover up the volume, will it give some help in management? What do you think? There is obstructive shock, but still there will be some response to volume or not. Like for example, if we discuss about pulmonary embolism, what happens in pulmonary embolism? Yes, Dr. Mahjabin.
In pulmonary embolism, the flow towards
We are little loud.
the flow towards the blood supply towards the lungs is compromised.
Okay, so actually you are saying that because of any physical obstruction, maybe air, maybe clot, maybe
Yes.
immunological response or anything, now the blood is not going towards the lungs. Okay, so one effect will be that there will be no blood flow going to the lungs, so there will be nothing coming towards the left ventricle. Am I right? Because if nothing is
Yes.
going, so this is one of the reason. There is another reason for it, the failure. What will be that one? Just try to imagine the place. There is another happening which occurs. I had told before as well that when
Uh,
there is
the cause of
increase.
left ventricular failure, are you asking about it?
Yeah, yes, you are right, but actually what happens, that when there is increased volume in right ventricle, what will happen?
The pulmonary hypertension, pulmonary edema.
Mm, no, 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 no. Nothing is going to the lungs. Actually,
Backflow and
just
regurgitation.
no, just imagine about obstruction. Our chief guest is today is obstruction. Okay, so how this phenomena is causing obstruction to the left ventricle? It is pushing the septum. Okay, so
Yes.
actually when right RV dilate, it is pushing the septum towards the other side. So left ventricle compromise because of that thing as well. Okay. So this is just understanding of the phenomena what is happening. So one of the is the one of the reason for obstruction in this scenario. That's why we are labeling it as obstructive shock. Okay, that there is some obstruction to the flu. Okay, so that's why we just say that anything in the thorax, it may be intrathoracic obstruction by tumor, tension. What happens in now? Okay, now discuss about tension pneumothorax. What happens in tension pneumothorax?
The air is trapped in the thorax, the pleural cavity. The
Okay,
mediastinum is shifted to opposite
so
side.
what do you can you just improve your words? It's right, but what happens in simple pneumothorax? It is
In
also
simple pneumothorax,
pneumothorax is the presence of air in the in the thorax. Okay,
Collapse
so
of the
what?
lung and the pulmonary hypertension.
No,
Collapse of the lung and the pulmonary vasoconstriction.
no, no.
in tension pneumothorax, it's one-way valve. Only the air
One
can
way.
enter, but
Okay,
cannot
like it is
go out.
gradually increasing. It is increasing in there is no way out, and it is increasing with passage of time. So that's why it is compromising the cardiovascular system. Okay.
Yes.
So not only it is creating because in tension, that's the one of the T when we treat cardiac arrest. Can anyone tell the other T's, doctor? Anyone else who has done ACLS? If you want to speak out, what are the other T's of ACLS of the reversible causes? One is tension pneumothorax. What else? Yes, Mahajabi.
Thrombosis,
I'm sorry.
Mediastinal mass.
It's
Uh,
tamponade,
yes,
trauma,
trauma,
and tamponade, cardiac tamponade, trauma, toxin, and
toxins. There are
and
two.
thromboembolic phenomena.
Yes, actually,
Two types of
thrombosis.
thromboembolic phenomena,
Actually,
exactly.
thrombosis.
Thrombosis, yes.
Okay, so the one is pressure in the lungs, that is tension pneumothorax. One in the pressure in the heart, that is cardiac tamponade. Okay, and the other is trauma and toxin. Okay, so this is just sideway revision. Okay, so this occurs in what is this IPPV?
Intermittent positive pressure
Intermittent
ventilation.
positive.
Okay, so how it obstructs? Yes, Mahjabeen, can you explain what is difference between the
It
normal?
increases,
Just
sir, it
anyone.
increases intrathoracic. Okay, sorry.
Okay,
Sir,
Galia.
IPPV increases intrathoracic pressure and it
Okay,
obstructs normal flows. It
okay. So
increases
what?
intrathoracic pressure, so hampering the flows.
Okay, so what is difference when we are normally ventilating, normally breathing, and
When okay, so when we are normally breathing, we are actually creating a negative pressure environment in our lungs, and so
okay.
the intrathoracic pressure is actually dragged down to more negative, and the air is sucked in. So there is no pressure on obstructive pressure on the arteries flowing.
No,
That's
it
why
is.
it does not cause obstruction.
Yes, it is. It is helping actually. It is just like you
It is
are
helping actually. Yes, we are
the
actually
thoracic
sucking the
cavity.
blood in as well.
Thoracic cavity is actually sucking the blood as well. Okay, because in normal individuals, when this is the mechanism of venous return as well. There is a peripheral pump which is the muscles
Yes.
of the like coming from the back. That's why if this stone and this vasculature system is not active, which occurs in if the patient is taking any antihypertensive medications, which is causing vasodilatation, or this is one reason. And what else, Alina? What else reason which is hampering this thing and causing problem in this normal mechanism of venous return?
Uh, Sir, intrathoracic pressure,
No,
I
no, no, no,
cannot
no,
think
no,
of
no,
anything else.
no, 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 neuropathy. I'm asking about this venous return mechanism. Okay, because normally when we stand up, actually there should be decrease in venous return, but our
Exactly, yeah, the baroreceptor reflex problem. Yes, sir.
yes, our sympathetic system activates, and it is maintaining
Activate.
maintaining our venous return. Even if we are standing with the gravity, the blood should pool, and that effect is occurring in the patients with neuropathy. Okay, any patient with neuropathy, like diabetic neuropathy, or if you are atrogenically
Diabetic.
decreasing the vascular tone by giving vasodilators. Okay, so that's why it is called as we use this terminology for use of AC inhibitors as well as first dose hypotension. Okay, because the body is not tuned up to that thing, and that's why there can be exaggerated hypotension whenever they are starting vasodilators. Okay, so this is just critical thinking of your brain just to understand what's going on. Okay, so intermittent positive pressure ventilation also causes like that. So pulmonary embolism we have discussed. So now any embolism you are discussing, the basic mechanism is that there is obstruction, because amniotic fluid and fat embolism, that's why their effect may be subacute. Okay. As compared to that, if there is air or physical thrombus, the effect is more prominent. Okay. That's why some people claim fat embolism as amniotic embolism as atypical, because there is theory about there is a physical obstructive theory as well, but there is one immunological theory as well. That's why that is because of immunological, that response is not as acute PE occur, which occurs as a result of DVT, or acute embolism which occurs during any surgery above the level of heart. Okay, in which air embolism occurs. Just by the way, just for your brain exercise, I would like any of you to tell me what is another surgery, another not in the list of the surgeries which we say that it is the above the level of heart. What is that surgery in which air embolism or fat embolism can occur? Specifically,
Fracture femur, fracture
no,
long bones.
no, Dr. Humera, you have not understood my question. Fat embolism other than bony fracture.
Sir, open it, craniotomy. Sir, your voice is distorting a lot actually. I'm
Just a
sorry,
second.
I was unable to understand.
I will repeat my question. So, for example, if we say fat embolism, in which condition fat embolism can occur other than the normal mechanism, the bone and everything? There is another surgery.
Liposuction.
Liposuction. Very good. Okay. In liposuction, this surgery can occur, this embolism can occur other than the normal mechanism, common cause of, because fat embolism, you will always label it because of bone fracture. Okay. And in some tumors, without fracture, it can occur. Okay. This is another thing. And another point related to air embolism is related to laparoscopic surgery, in which usually we label air embolism as because of
Carbon dioxide insufflation in laparoscopic surgeries.
air embolism. What is the mechanism of air embolism?
Venous air embolism.
Venous air embolism.
Please raise the hand before talking. I'm asking the person who wants to speak out, please raise the hand so that we are not. Yes, please, Mahjabeen, what is the mechanism of air embolism?
The carbon dioxide that is insufflated in the
No,
peritoneum.
Mahjabeen, you are not understanding my, you are not listening to my question. What is air embolism? What is the mechanism of air embolism? Air embolism, not I will compare it with the other thing. Air embolism occurs because any surgery which is occurring above the level of heart, there is potential. If the venous system is open, there is chances of sucking in of air in the venous sinuses. That occurs in the craniotomies or any head and neck surgery, in which is even thyroid surgery, it can occur. But significant will occur if the dural venous sinuses are open. Okay. So this is the mechanism of air embolism. That's why we traditionally claim that air embolism can occur in any surgery which is occurring above the level of heart. Okay. The thing which you are talking in laparoscopic surgery, it is actually gas embolism. Okay. So it is gas embolism. Usually carbon dioxide is dissolved. Okay. And it is absorbed in the circulation gradually. But if, for example, when they are starting the laparoscopic surgery and they, by mistake, they put the trocar directly inside any vessel. So not only hemorrhage, severe hemorrhage can occur, it can inadvertently, in big amount, it is entering directly into the venous circulation, and then it will be above the level of the blood to handle it. Okay. So in that scenario, the picture will be exactly like air embolism. That's what I wanted to tell. Okay. So this is, now you have to think critically whenever you are dealing anything, that what are the possible complications which can occur, and you correlate your mind in this way. Okay. So embolism occurs like that. Okay. So that will be the ultimately what will occur. The ultimately in just like this constrictive pericarditis or pericardial tamponade. Okay, the result is that now the heart chambers are not able to be contracted. Like they are not able to fill first, and that not able to contract nicely. Okay, so if we will just try to have some words about cardiac tamponade. Okay, that cardiac tamponade is the accumulation of fluid in pericardial sac. Okay, creating an increased pressure within the pericardial space that impairs the ability of heart to fill and to pump. First of all, the heart will not be able to fill, and then if according to Frank Starling law, if it is not filling properly, the contractility will also go. Okay. So another terminology which is being used for cardiac tamponade, any exam candidate, if take the lead. Sumera, what is Bex Triad?
Sir, in Bex Triad, there are three components.
Okay.
One is hypotension and muffled heart sound and raised JBP.
Okay. So how will you correlate them in the Bex Triad? What happens actually?
Sir, due to pericardial effusion, there will be decreased contractility, so there will be decreased cardiac output, leading to hypotension, and there will be fluid around the heart, so heart sounds will be decreased. So we call them muffled heart sound, and
Yes.
there will be decreased preload, we can say, decreased cardiac filling. So JVP will also be raised.
What is? Can anyone explain pulsus paradoxus?
Yes, sir. Pulsus
Yes, Arsalan.
paradoxus is the decrease in blood pressure of 10 mHg. Oh, when we measure blood pressure at different limbs.
No. You know, again, Arsalan, I just give the evidence that if you don't understand and you just try to recall and remember the words of the book, you are embarrassed in the way you are embarrassed at the moment. Just try to understand. Actually, pulsus paradoxus is normal. Actually, pulsus paradoxus. Yes, Nasida.
The pulsus paradoxus is during inspiration, there is a fall in blood pressure. And so the
No,
Right.
this is occurring normally. So when you say it,
Normally.
this is a normal, it is exaggeration of the normal response. Okay. Up to 10
Yes, sir.
millimeter of mercury is normal because of the normal like physical principles occurring. There is negative pressure, there is increased venous return, expiration, there is decreased venous return. So it is in the form of the normal, which says normal RR variability. Okay. So that is occurring normally. If it is increased, the degree, like they have labeled it as more than 10 millimeter. Okay. So then they say it pulsus paradoxus. Okay. And reverse occur in the sedated patient, this paralyzed patient. Because the physiology now, it is not negative pressure ventilation, it is positive pressure ventilation. So the mechanism is different. Okay. Okay, Nashida.
Yes, sir. Okay.
So, so now what will be the any other clinical features, like there will be sudden cardiovascular collapse. It may occur, cardiac tamponade may occur post cardiac surgery usually, okay, or after any trauma, aortic dissection, malignancy. Actually, it is anything which is obstructing it. So main, remember one thing, either it is infective cause like pericarditis or pericardial effusion. In overload patient it can occur, or like infective cause, overloaded condition, or any trauma, or post cardiac surgery. Post cardiac surgery, because they have already do surgery in it, so pericardium is open and now then closed, so it can occur. Okay. So if there is any bleeding problem, it can occur, or spontaneous in some bleeding disorders. I think it can also occur. It's not written here, but I think it can occur in any potential space. Bleeding can occur if there is any bleeding tendency. This is just came into my mind. So you have to look into the cause, and the treatment of a cardiac tamponade will be revolving around airway, breathing, circulation, and ultimately, if you have a, you can put the echo probe in ICU. Usually, these patients, they can present in ward as well. They can present in OR as well, but usually this condition is occurring in specific scenarios. And usually, if it is following trauma, you can have a patient inside the OR, you are doing surgery for any trauma, and maybe in the primary survey it was not taken in consideration, there were rib fracture or something like that, and now patient suddenly is collapsing out of context of what is going on there at the moment. So you have to rule out cardiac tamponade because of increased fluid in the pericardium. Like you are squeezing the how heart will be able to tolerate. The only actually treatment will be the pericardiocentesis. Like in that scenario, if there is the cause is the or presence of blood or fluid, you have to remove it. Otherwise, heart will not be able to maintain the cardiac output. Okay. So recognition, they have written, it may be acute or it may be chronic as well. Chronic will be related to infections or any other cause. Okay. Like in occur, you see collagen vascular diseases in which pericarditis occur. Okay. Rheumatoid arthritis and thyroid problems. So usually when they are asking you, they are expecting majority cases in the acute rather than chronic, because it goes in the domain of cardiology usually. Okay. So if they are asking about cardiac tamponade, you should be knowing this is the question which they ask in the MCQs as well. Hypertension, elevated JVP, and muffled heart sounds. Okay. And try to not ratify, just try to understand it, so that it will be when the heart chambers are not contracting, there will be bazaar. So that bazaar is muffled heart sounds. There will be obstruction in the entrance and outside. So because of problem in the entrance of heart, JVP will be raised, and because of outside exit of the heart, their cardiac output is not maintained, so there will be hypotension. Okay. So this is what you need to know about Bex Triad. It may be diagnosed usually echo, or ECG, or chest X-ray may also be helping. Other than that, the invasive monitoring and the clinical sign symptoms. Okay. Simple investigation. You have written the same thing which I was telling you. ECG, chest X-ray. Okay. What else? Global heart shape, chest radiograph reflecting expansion of pericardial sacs within the surrounding fluid. Okay. This is the thing. And they specifically in ICU exam, they can ask you now these things as well. Diastolic collapse of anterior right ventricular free wall. I don't have much idea. I'm just reading it out. And very rarely left ventricular collapse may also be seen. Increased left ventricular diastolic wall thickness described as pseudo hypertrophy. Inferior vena cava dilatation without respiratory variation in size, suggesting raised right atrial pressure. Okay. So I have seen a lot, but I don't understand much of it. And I don't think so they are expecting such things. If in the basic anesthesia exams, even if you are able to tell what is it, how it is presented, how you have to use the echo, ECG, and the clinical, mainly will be, there will be something, some cause behind in the history. There will be some symptoms, some signs in the monitoring and the investigations which warranted, because you don't have to delay. Okay, you have to proceed, you have to diagnose and treat in a quicker way. Okay. Differential diagnosis will be low cardiac output rate as in cardiogenic. Okay, so now the thing is that how will you differentiate between cardiogenic shock and obstructive this cardiac tamponade? Anyone? Yes, Nashida or Mahjabeen, or anyone wants to speak out? Sumera?
JVP won't be elicited actually in cardiogenic shock.
JVP will be raised here as well.
By
Sir, there will
muffled
be
heart
muffled
sound.
heart sound in
Mm,
tamponade.
Actually, it will be major. Of course, there will be some, muffled heart sound cannot be there in. What about this third, fourth, fifth heart sounds? You're right. Muffled heart sound is one of the thing, but actually, practically, the response to the inotrope will not be there. Am I right? Even if you are
Yes, sir.
giving even if you are giving inotropes, the response will not be appropriate. Rather, if you are giving something increasing the contractility, as occur in which type of cardiomyopathy, in which you are actually not giving the inotropes. What is that type of cardiomyopathy? Hypertrophic,
Hypertrophic.
obstructive cardiomyopathy. Okay. So in that, because in that condition, if you are giving excessive inotropes, actually it is creating more problem, worsening of the symptoms. So this is the only way. Otherwise, clinically, if you have a normal patient there, because cardiomyopathy, the picture of cardiac tamponade can mimic like a cardiogenic shock. Okay, so that's why you have to do echo. That's why the importance of focused echo is of utmost importance now. Okay, for the people who are doing ICU, or who are like from because some part of world ICU anesthesia and separate, but if you are working in a place where you have to deal both in anesthesia and ICU, I think you cannot work in 2022 if you don't have the knowledge of echo. Okay, so that is for juniors. I will suggest you highly that if you are able to have some information about echo, of course, you will not find it any teacher from anesthesia ICU side. You have to spend some time with the cardiologist, but don't try to learn the echo as cardiologists are doing it, because that is too much for you and you don't require the echo. Focused echo means that you have to get the answers in yes or no, responding or not responding. Okay, so you don't need to have the echo. What the cardiologists are doing measurements, it's not that much significant. You have to get the focus result. Okay, so that is a message which I just wanted to tell. Correct, so wheel tumor. Okay, so okay, role of fluid, that's I told you that in actually you have to the same airway breathing circulation approach. Actually, what happens if you are trying to do the intubation, maybe at the time of intubation, patient will collapse, because whatever cardiac contractility was there, if you are giving any cardiac depressant medication, you see that's where they have written it should be avoided unless it's strictly necessary. Okay, or it should be done only in the environment where you are able to do whatever you are doing. You have to be ready for the next step. So this is something where when you are answering this question, you have to keep some attention to this point. Okay, and you can give colloids, crystalloids according to use of inotropes and vasopressor, as I told you, that they will be helping you, but you have to check it out what's the exact situation. Okay. Drainage, as I told you, pericardiocentesis is the one. Surgical drainage, this is actually, you should have a that you have to immediately involve the multidisciplinary team. You will be supporting the patient, and you will be diagnosing on the, if you have the skill. Otherwise, you will be calling the help, getting the help of the cardiologist and cardiac surgeon, and they will be managing it. Okay, so these are few words about cardiac tamponade. Okay, I want to discuss some points about the.
Dr. Zishan, how will fluid therapy help this obstructive shock?
You are just supporting it. You are just supporting it. If any, it is not that, because even if you are giving too much fluid, it will not help. If it is the clear-cut cardiac tamponade, it will be just be the bridging therapy in between, where you are just trying to support the heart by maintaining the volume. This is only that thing. Okay. I was just searching cardiomyopathy. That is also how to search. If you want to search any topic, you will find articles related to that search. Just a second. Actually, there was a old article about cardiomyopathy. Once upon a time, we discussed. Okay, so here, if you focus on this hypertrophic, so cardiac output is low, stroke volume is low, contractility actually is increased. Okay, because heart is trying to compensate it. So in this scenario, just a second, please. In this scenario, actually, this is if you know this chart, you can handle any type of, because you know how dilated cardiomyopathy occurs usually in the heart failures when after in any valvular regurgitation, this dilated cardiomyopathy occurs. Okay, and peripartum cardiomyopathy is also one of the type of it. Okay, so hypertrophic and restrictive. Okay, so these are actually the focus in which there can be picture of this one obstructive shock in both of them. Actually, it can occur presented like that. Like restrictive, what is difference between restrictive and hypertrophic? Anyone, please?
Contractility is like low and good in
Contractility is what? In
is
hypertrophic,
ready.
actually contractility will be increased. Okay. And in restrictive, it may be.
left ventricular volume.
I'm sorry.
So left ventricular volume.
Not left
Decrease in
ventricular
height.
volume, because in dilated, it is dilated. Okay. So that is different. Because hypertrophic and restrictive, they are a little different sort of pathologies going on. We will just have a look here. Okay.
Right ventricular failure.
Right ventricular failure is what?
Sir, in dilated cardiomyopathy.
No, Dr. Romero. it is different. Dilated cardiomyopathy, right ventricle, we are talking about left ventricle mainly. Okay. So this restrictive cardiomyopathy occurs usually in the this connective tissue disease like amyloidosis, sarcoidosis, hemochromatosis. Okay, and it is diastolic dysfunction is a major clinical feature, producing reductions in ventricular compliance. It is not dilating, accommodating. So it is sort of, you can say, that which occur in the hypertensive patients. It is slightly similar to that one. Okay. Biventricular dysfunction may occur with the right ventricle being more commonly affected. Okay. This is in restrictive cardiomyopathy, not in the dilated cardiomyopathy. Dilated
It
cardiomyopathy,
means the contractility will be decreased.
yes, contractility may be decreased. We will just have a look on the hypertrophic as well, because in hypertrophic there is obstruction. Okay, so here there is actually in this cardiomyopathy there is connective tissue disorders usually, and you see in the form of amyloidosis, sarcoidosis, hemochromatosis, and there is decrease in contract. This actually, it is starting from the relaxation. So when there is problem in the diastolic function, dysfunction, ultimately it results in the failure. Okay, hypertrophy of the ventricle is absent, and systolic function remains normal until late in the disease. Initially, there is a problem in the relaxation of the heart. Okay. Because in dilated cardiomyopathy, volume is there, but contractility is problem. So that is a little bit different in restrictive cardiomyopathy and dilated cardiomyopathy. Okay. And in hypertrophic cardiomyopathy, what happens? Just a second. Yes. In that there is obstruction. So there is as a result, there is contractility is increased. Okay. Diagnosis is based upon unexplained left ventricular hypertrophy, which may be concentric or asymmetrical, diffuse or focal. Okay. The pictures are similar to aortic stenosis. Okay. There will be syncope. There will be chest pain. Okay. This is just like symptoms like aortic stenosis. Okay. Anyone wants to comment, please? We use beta blockers in it to reduce the contractility actually. Okay. Similarly, like it is decreasing the infundibular muscle tone, because if it is contracting too much, actually it is decreasing the cardiac output rather than increasing it. Okay. You see left ventricular outflow tract obstruction in a subset of high-risk patient. Hypertrophy is most prominent in the interventricular septum. This leads to dynamic left ventricular outflow obstruction in the subaortic region. This is exacerbated in situation where there is underfilling of the left ventricle with forceful subaortic narrowing. The velocity of the blood in outflow draws the anterior mitral valve leaflet towards the interventricular septum. The result can be complete obstruction of the outflow tract coupled with mitral regurgitation, as the anterior mitral valve leaflet is pulled away from the posterior leaflet. Actually, it is very actually it's a difficult topic. Okay, I'm trying my level best to give you an insight. Okay, because usually it's not a very high yield topic in the exams, but you should have an idea when you are comparing it. So comparison is important. The general concept is that in hypertrophic cardiomyopathy, you don't have to increase the contractility because contractility is already more. So you are using actually beta blockers. Okay. And you are just trying to reduce the SVR to maintain the cardiac output. It's just like when I read it like aortic stenosis. some of the targets which you want in hypertrophic is actually, you see, maintain preload, because there is the same feature which we use in aortic stenosis. Heart rate is between 60 to 80. The similar which we use in aortic stenosis. Maintain sinus rhythm, which is always there. Because here again, as they were telling you, that the atrial click is very important. If atria are not contracting, the cardiac output will not be maintained. So if any rhythm like atrial fibrillation occur, it will not be able to compensate it. Okay. And contractility, you want slightly reduction in contractility, but don't have to depress the heart, because if you depress it, you will not be able to maintain the cardiac output. Okay. And you have to maintain the this one SVR. Actually, you don't let it go down, because if you let it go down, the similar thing occurs which we face in aortic stenosis. If you give spinal or epidural in aortic stenosis or mitral stenosis, that you have to maintain it. Yes, they are saying, I little doubt on this word, increase slightly. You have to maintain it and don't let it go down, because if you increase it a lot, even that will be creating problem, because heart contractility is already high. Okay. So you don't want to increase it more, because there is obstruction in the pathway. So even if you increase the contractility, it will not help a lot. Okay. And in dilated cardiomyopathy, you see low, there is everything is low. Cardiac output is low, stroke volume is low, contractility is low. And here you have to maintain the preload. Okay. Because left ventral and diastolic pressure is already there. There is heart is dilated. So the back pressure is already there. That's why these patients can go in pulmonary edema very easily, because the pressure behind going towards the lungs is more. And you don't have to, like in any patient, if you have tachycardia, patient will be collapsed, because the filling which is already hampered, you are not able to have the filling, and cardiac output will be decreased. Okay. Maintain sinus rhythm, inotrope support often required. Here you have to use inotrope. Okay. And here you don't have to let it increase. You have to maintain it or slightly on the lower side. That's what we do in heart failure treatment, that we give vasodilators to maintain the cardiac or the support the cardiovascular system. We give just like in any cardiac, even yesterday we discussed about cardiogenic shock. We are having the same thing. Okay. So I have just tried to give you some idea. As much as I know, I have just tried to explain it to you. But I tell you, it's a difficult topic. Okay. So anyone wants to add to it, we will just have few words about tension pneumothorax, and then we will finish this topic. Any comment on this topic, please? Because I don't have too much knowledge for this topic. Okay. So tension pneumothorax, some words about tension pneumothorax. What is tension pneumothorax, Sumaira? How you deal if you find a patient with tension pneumothorax? What will you be doing?
Sir, in tension pneumothorax, there will be collection of air in the
Okay, Arsalan, if you want to tell.
Yes, sir. It is a medical emergency in which there is a collection of air in the pleural cavity, and it does not exist from air. It is continue adding it and compressing the heart and lungs and diverting the trachea and mediastinum to the opposite side.
Usually, what will be the features on inspection? There may be respiratory distress signs. Okay. You can have deviation of the airway, like trachea to the other side. What else? There will be hyperresonance, okay, and no breath sounds. Okay, what else? And then it will be combined with cardiovascular collapse. And in some of the causes, like you see, if you do, there may be a procedure you have done, it can cause tension pneumothorax. Usually it will be simple pneumothorax, but it can be converted to tension pneumothorax. Okay. And if you have some trauma and the rib fracture, the flail chest mechanism, it is one-way movement, air is sucking in and not going out. So that is what you will be facing in it. And then how will you manage it? What will be the management?
So in management, as it is a medical emergency, so we have to go for needle decompression at the second intercostal space, and after that we have to plan chest tube.
Yes, you will. So that's what I was telling you. Symptomatic patient, there may be pleuritic chest pain that can radiate to the ipsilateral back or shoulder. There will be pain related to the rib fracture as well if it is occurring. Then, as I told you, signs of respiratory distress, increased respiratory rate, dyspnea, retractions, and then you will be decreased or absent breath sounds on the reduced tactile. These are dated. I'll just give you an idea. So you can add these things. Reduced tactile, fremitus, hyperresonant, percussion note, okay? And in asymmetrical lung expansion, and then combined with hemodynamic collapse. You can do it via ultrasound. You can find it via the X-ray. Okay, and treatment will be as you told, needle cricothyroid. In addition to that, you have to tell about airway breathing circulation. You have to tell again, you always forget this thing. Immediately call for help. Immediately call the surgical team. And then in this time, you are giving 100% oxygen. You are trying not to give nitrogen. Nitrous oxide, because it will increase this problem. So you are giving 100% oxygen, and then you can do the positive pressure ventilation. But if you want to do it, you don't have to give too much pressure. If there is no other way, here they have written should be avoided initially, as it will contribute to increasing the size of tension pneumothorax. But for example, if patient is collapsed, you have to support it. But if you are doing it, try to not to give too much airway pressures. Okay. Because that's why, for example, if you read like this and just reproduce it, the examiner will say, okay, patient is not breathing, so you will not ventilate the patient. So you have to understand the words written in any text. Okay. So I hope you understand. So then you will be doing that needle and then going to chest tube, the formal chest tubes. Okay. What will be the differential diagnosis? As we discussed, pulmonary embolism, acute coronary syndrome may present like that. Okay, acute aortic dissection, because because you know all these which is written here actually are the diagnosis. The differential or presentation is from which we started, obstructive shock. Okay, so everything which we have discussed, majority of things are there in the obstructive shock. Okay. So you will be doing some investigation and seeing it, consultation from thoracic surgeon, pulmonologist for the further management, and complication which may occur even if you are doing the needle cricothyrotomy. You can rupture some viscera. Okay, sorry, you can rupture some vessel, so it can itself cause hemothorax. So these are the things which can occur, and according to the pathology, there may be some complication, like if there is some post surgery, there may be development of bronchopleural fistula, bronchopulmonary fistula. Okay, so that is how to manage tension pneumothorax. What will you do in air embolism? You will do the head side down. You will irrigate the area, again airway breathing circulation. You will irrigate the area head side down, and you will put the you will ask the surgeon to cover the area, irrigate a lot of saline, and try to put the bone wax. Okay, if there are obvious opening of dural venous sinus. If you have transthoracic echo, you can diagnose it earlier as compared to loss of untitled CO2 or hemodynamics collapse will be there. Other findings in decrease untitled CO2 and increase untitled nitrogen will be there. Okay, and you will, if you have central line, you will try to aspirate the air. That will be the management. In addition to that, this typical airway, breathing, circulation, hemodynamic support, cardiovascular support, the use of inotropes, vasopressors to support the blood pressure. And if cardiac arrest occurs, you have to do the CPR according to ACLS guideline. This is the management of air embolism. Okay. The presentation, diagnosis, differential diagnosis we have discussed, and how to manage it. If fat embolism or amniotic fluid embolism occur, almost the same thing, nothing different. The prevention and further is that you have to fix the fracture. If the patient is stabilized, the usual approach will be that you stabilize the patient, but you do the surgery, because if you don't do the surgery, there will be chances of another fat embolism. Okay, because if in any long bone fracture, there are always chances of pulmonary fat embolism, because this is a scenario which they can ask to the people who are going in oral part, that they will give you a scenario that there is a patient on the table with the fracture and you are trying to shift it, and the same time patient became unconscious. So what is differential diagnosis and what will you do? Actually, if you hemodynamically support the patient, then you will be discussing with the surgeon, and if the patient is stable enough to proceed with the surgery, it is better to proceed the surgery, because of orthopedic, no orthopedic surgery is elective. You have to do it unless joint replacements or sport injuries. All other orthopedic fractures are never elective. Okay, so pulmonary embolism, the same will be the hemodynamic collapse, and then you are trying, there may be some risk factor as DVT or obese patient. You can see any risk factor, prolonged surgery, dehydration, things like that. And then you are again doing the hemodynamic support, and then because there will be use of RTPA and things like that. So that will be further according to the advice of the physician. Okay, so that is how you are dealing with this topic. I just try to give you an insight, because usually maybe this topic will not be asked you in this scenario in this way, but either of them, if it is asked, you should be knowing what actually is going on, and you should be knowing about the differential diagnosis and how to differentiate between different types and how to manage it. Okay, so any question? Anyone, any comments? Do you understand, Mahjabeen, Sumaira? Anyone else?
Yes.
Yes,
Okay.
sir. Yeah.
Okay, so I hope there was some advantage. We will discuss some other topic tomorrow, inshallah. Okay, thank you very much.